Welcome to the deep dive. Today we'll be going over a topic that's pretty important for the FRCS exam, metacarpal and phalangeal fractures.
10% of all upper extremity fractures.
Exactly. 10%, that's huge.
And remember, your thumb and pinky are the most common ones that are
Oh,
involved.
for sure.
Yeah.
Especially in that age group, like 11 to 45 years old.
Yeah, for sure.
And operative fixation really is the standard now.
Yeah.
But it's kind of crazy to think that's only been around for like, what, 80 years?
Yeah, about that. And fracture stabilization and early mobilization.
So key.
Those are the two biggest things for a good outcome.
Yeah, those are the things you want to make sure you get right.
Yeah.
All right. So before we dive into all of that, let's get our anatomical terms straight. So when we talk about the diaphysis, what are we talking about?
That's the shaft of the bone.
Mhm.
And the metaphysis is the flared end of the bone, usually proximal.
Got it.
And then you have the physis, which is your growth plate,
Hmm.
and the epiphysis, which is the rounded end of a long bone.
Okay. So the metaphysis and physis are located between the diaphysis and epiphysis.
Correct.
Okay.
Yeah.
And of course, we have soft tissue landmarks, which are important as well, but we won't go into detail about those figures now. Let's get into fracture types.
Yeah.
This is really just pure terminology for the exam. So when we say closed fracture,
That means the skin is intact over the fracture. Open fracture means there's a wound exposing the fracture. And by the way, forget the term compound fracture. It's
Yeah.
outdated.
yeah, nobody uses that term anymore.
Yeah.
All right. Simple fracture, two bone fragments, comminuted fracture.
More than two bone fragments.
Okay. And you're also going to want to know transverse, oblique, spiral, impacted, longitudinal, pathologic, stress, green stick, avulsion, and intra-articular fractures. All those describe the nature and position of the break.
Yeah, that's right.
Okay. And then, of course, we have to think about our pediatric cases.
Right.
And that's where the Salter-Harris classification comes in. Can you take us through those 5 types?
Sure. So type I is a fracture through the growth plate, only type 2 involves both the metaphysis and the growth plate. Type 3 is through the epiphysis and the growth plate.
Okay.
Type 4 affects the epiphysis, the growth plate, and D, the metaphysis.
Oh, wow.
And type V, that's a crush injury of the growth plate, has a high risk of growth arrest and deformity.
Yikes.
Yeah.
Okay. So let's talk about how a fracture actually heals. There are 3 phases of healing: inflammation, repair, and remodeling. Can you break those down?
So inflammation starts immediately after the injury and lasts for a few days. You get hematoma formation, and cells move in to start that healing process.
Okay.
Repair kicks in within the first 24 hours. It peaks at 2 to 3 weeks. That's when you get collagen laid down and callus formation.
Got it.
And remodeling takes months, even years, to fully form that lamellar bone, repopulate the marrow, and resorb the callus.
Oh, wow.
Yeah.
Okay. Now, couple of clinical pearls here for our listeners. External callus won't show up on X-ray for 3 to 6 weeks after it actually forms.
That's right.
And you want to avoid NSAIDs in the acute setting
Yep.
because those can interfere with healing.
That's right.
Okay. Moving on to diagnosis. Where do we start?
With a thorough history, hand dominance, occupation, and mechanism of injury.
Okay. So physical exam we're looking for.
Tenderness, deformities, malrotation.
And really importantly,
Check the neurovascular status before you give any anesthesia.
so critical.
Extremely important.
Yeah, you don't want to miss any of that. What about documenting those open wounds?
You need to document those accurately
Huh.
using a grid system and photographs.
Okay. And of course, we need our standard radiographic views for diagnosis as well.
Exactly.
Okay. So how do we decide on a treatment plan?
You've got to consider the patient's characteristics, the specifics of the fracture itself, any deformity, the open or closed classification, soft tissue injury, and stability.
So it's a balancing act, really.
Yeah, it is. You have to weigh the risks.
You have to balance that early motion with adequate stabilization. Let's talk about some complications our listeners need to be aware of. What's the first one that comes to mind? Yeah, infection's a biggie. What's the incidence in open fractures?
Anywhere from 2% to 11%, usually from wound contamination or delayed treatment.
Hmm.
And you want to give those patients antibiotics for 24 hours.
Absolutely. And how do we manage an infection if it does happen?
You need to tackle the sepsis,
Yeah.
get the fracture to unite, and restore function.
Okay. Another problem is malunion, which can manifest as...
Malrotation,
Uh-huh.
angulation, or shortening, all of those can affect function.
Right. And what do we do about a malunion?
Often you need to fix it with a corrective osteotomy, maybe a bone graft too.
Okay, let's talk about non-union.
Yeah,
That's when the fracture just doesn't heal.
yeah.
There's a trophic non-union.
Or you don't get callus formation.
Okay.
And hypertrophic non-union, where you get callus, but there's still a gap on X-ray even with immobilization.
And how do we manage non-union?
Similar to Meloonian corrective osteotomy and possible bone grafting.
All right. And lastly, loss of motion can result from...
Tendon adhesions,
Okay.
capsular contracture, keeping it immobile for too long,
Right.
joint injuries, multiple fractures in one finger, or crush injuries.
Okay. So now that we've got those basics out of the way, let's dive into specific metacarpal fractures,
Sounds good.
starting with the head.
All right.
Metacarpal head fractures aren't all that common, but when they do happen, it's usually from...
Axial loading, direct trauma,
Okay.
or dislocation.
Okay. And they're often intra-articular. What does that mean?
It means they involve the joint surface.
Okay. What are we looking at to decide on treatment?
Look at articular congruency, metacarpophalangeal joint stability, and how much of the articular surface is affected.
Okay. So when can we manage these fractures non-operatively?
If it's a closed fracture
Kicking.
and the joint surfaces fit well,
Huh.
the MP joint is stable, and less than 20% of the articular surface is involved.
Okay. And when do we need to go to the OR?
If over 25% of the articular surface is involved, if there's a step-off of more than 1 millimeter, if the fracture can't be reduced, if there's malrotations, soft tissue injuries, if it's a two-part fracture that can be fixed with headless screws,
Okay.
if it's an open fracture, or if it's comminuted.
So what are our treatment options for these?
Immobilization, closed reduction and pinning,
Ooh.
open reduction and internal fixation, external fixation, prosthetic arthroplasty, and arthrodesis.
All right. So let's talk about simple fractures. How do we usually approach those?
With the dorsal approach,
Okay.
using mini condylar plates or screws, you can use K-wires, but they might delay joint mobilization.
Got it.
And buried headless compression screws are another option.
And comminuted fractures.
For those, you might need K-wire fixation or circlage wiring to avoid a vascular necrosis. And if it's really messed up or there's major soft tissue loss, you'll probably need an external fixator.
Okay. What about implant arthroplasty?
That's an option for severely comminuted fractures, but not in the index finger. Too much risk of the implant failing from shear stress. And MP arthrodesis is usually a last resort.
All right. So let's move on to metacarpal neck fractures.
Pretty common, right? They are, usually from axial load on a clenched fist.
Typically, they angulate dorsally.
That's right, because the intrinsic muscles are volar to the MP joint's axis of rotation.
Got it. And do these usually heal well?
Almost all of them heal,
Okay.
but angular Meloonian is common.
Now, there's this term, boxer's fracture, which is a metacarpal neck fracture of the small finger, but I've heard that that's actually a bit of a misnomer.
It is.
Yeah.
Professional boxers rarely get those. They're more likely to have sagittal band ruptures at the MP joint.
Interesting. So what factors determine our treatment plan for these fractures?
Angulation.
Rotational deformity or scissoring,
Okay.
and shortening. How much angulation you can accept depends on the finger.
Oh, okay.
The ring and small fingers can handle more than the index and middle fingers.
Okay, that makes sense.
Yeah.
So what about non-operative management for metacarpal neck fractures?
Most closed metacarpal neck fractures can be treated non-operatively.
With casting or splinting, just warn the patient that the knuckle might look depressed, even though they should get full function back.
Okay. And if you can't keep it reduced after a closed reduction?
You can use K-wires in various configurations.
Okay.
Only use plate fixation as a last resort
And why is that?
to minimize dissection and the risk of MP joint stiffness.
Makes sense. What about closed reduction techniques?
Like the J's maneuver.
Yeah.
Those are used to fix malrotation or pseudocline. You flex the MP joint to 90 degrees to relax the intrinsic muscles and tighten the collateral ligaments, then manipulate the fracture fragments.
Yeah.
And if you have to do an open reduction, you'll usually use a dorsal approach and fix it with K-wires or a mini condylar plate.
Okay.
After surgery, immobilize it and start protected range of motion exercises.
So there's some debate about the best way to treat these metacarpal neck fractures.
There is.
Different studies have conflicting results about different immobilization and mobilization protocol.
Yeah, that's true.
Okay. Let's move on to metacarpal shaft fractures. How do we classify these?
Based on the X-ray, they're classified as transverse, oblique, or spiral, and comminuted.
Okay. So transverse fractures, where do those usually come from?
Axial loading.
Okay.
They angulate dorsally because of the interosseous muscles. You should reduce them if the angulation is more than what's acceptable for that finger.
Okay.
And oblique or spiral fractures happen from torsional forces.
Yep.
It can cause rotational malalignment. It's important to check for that clinically because it might not be obvious on X-rays.
Got it. And comminuted fractures.
often from direct impact. They're frequently associated with soft tissue injuries and often lead to shortening.
Okay, so how do we treat metacarpal shaft fractures?
Depends on the dorsal angulation, rotational deformity, and shortening. Again, the small finger can tolerate more angulation than the index and middle fingers.
Right, and if it's stable?
Stable metacarpal shaft fractures are often treated with closed reduction and immobilization.
Okay, but what if it's unstable? Or an open fracture?
Then you'll need surgery.
Okay, and what are our options for surgical fixation?
Depends on the fracture pattern.
Okay. What about closed reduction and percutaneous pinning?
You can do that either antegrade or retrograde, but be careful. Pins can get in the way of extensor tendons if they're not buried, and you can get pin tract infections.
Oh.
Transverse K-wires are another option.
Got it. So when do we usually go for open reduction and internal fixation?
If it's an open fracture, multiple fractures, unstable, or has bad alignment or malrotation.
Okay. And what are our fixation options then?
You have a bunch of options: K-wires, composite or tension band wiring, cerclage and interosis wiring, intramedullary fixation, interfragmentary compression or lag screws, plate fixation, and external fixation.
Wow.
Each one has its pros and cons, and they're used for different situations,
Right. So how do we choose the right method?
based on the fracture and your own experience and preference.
Sounds good. So let's shift gears a little bit and talk about those metacarpal shaft fractures with segmental loss. And these almost always involve those open injuries with soft tissue loss.
Yeah.
And so what's the first thing we're thinking about?
Debridement.
Yeah, we got to get that debridement to prevent infection.
Absolutely.
What about stabilizing the bone? What's the ideal time frame?
Ideally within 10 days of the injury.
Okay.
And you're going to use bone grafts and internal fixation.
Okay.
And you can use some temporary things like transfixation pins, external fixation, methyl methacrylate spacers, or a combination of those to maintain length until you do your definitive reconstruction.
So what kind of bone graft are we typically using in this situation?
Autogenous iliac crest corticocancellous grafts.
Okay.
Going to use that to bridge the defect.
All right. Let's move on now to metacarpal base fractures.
Okay.
And those are relatively uncommon.
Yeah, less common.
What are our typical mechanisms of injury?
Axial loading on a volar flexed wrist or a partially flexed thumb.
Okay.
And they often involve the joint surface,
Yeah.
which makes them a little more complex.
Now, one specific type we need to know for the exam, the Bennett fracture.
Yeah.
Can you break that down for us?
So a Bennett fracture is a two-part fracture of the thumb metacarpal base.
Okay.
You have a single volar ulnar fragment that stays attached to the anterior oblique ligament
Okay.
or the volar beak ligament.
Mhm.
And the rest of the metacarpal subluxes dorsally because the abductor pollicis longus is pulling on it.
All right. And what about the reverse Bennett fracture?
The reverse Bennett fracture involves the fifth metacarpal base.
Okay.
The metacarpal subluxes proximally and dorsally because of the pull of the flexor carpiulnaris, extensor carpiulnaris, and abductor digiminimi.
All right. And we can't forget the Rolando fracture.
Right.
What makes this fracture stand out?
The Rolando fracture is a comminuted intra-articular fracture of the thumb metacarpal base.
Okay. Now, in terms of treatment for metacarpal base fractures in general, what's our general approach?
So because there's a dislocation component, it's usually treated surgically.
Okay.
Whether you do an open or closed reduction. Okay. Depends on the fracture pattern.
All right.
So if you've got multiple CMC joint dislocations,
Uh-huh.
you're going to want to do an open reduction.
Okay, so let's say we have a simple fracture. What are our options then?
If it's simple, you can do a closed reduction and K-wire fixation.
Okay.
So to reduce a Bennett fracture, you apply longitudinal traction, pressure at the thumb metacarpal base, and pronate the hand.
Mhm.
And then you put in K-wires across the thumb metacarpal into the trapezium and second metacarpal.
All right. And if we have to go for open reduction of a Bennett fracture, what's our approach?
You make an incision along the radial border
Okay.
and use screws or K-wires to fix the reduced fragments.
Okay.
But interestingly, you don't usually have to fix the actual Bennett fracture fragment.
Oh, that's an important point for the exam.
Yeah.
Now, what about Rolando fractures? We got all those fragments. How do we manage that?
So Rolando fractures are best managed with closed K-wire fixation because they're comminuted.
Okay.
But if you can use a mini plate to fix the bigger fragments. Okay.
If it's really comminuted, you might need an oblique traction pin or a quadrilateral external fixator.
All right. Reverse Bennett fracture dislocations.
Yeah.
We said these are unstable.
Yeah.
How do we approach a closed reduction here?
So for a closed reduction, you're going to use longitudinal traction
Mm-hmm.
and volar pressure at the base of the fifth metacarpal.
Okay.
Then you use K-wires to fix the fifth finger to the fourth metacarpal and the hemit.
Okay.
Or you can use a plate.
All right. And if we need to do an open reduction of a reverse Bennett fracture?
For an open reduction, you make a dorsal ulnar incision.
Okay.
Be very careful not to injure the dorsal sensory branch of the ulnar nerve.
Right.
And you usually fix it with multiple K-wires.
Okay.
If the patient develops arthritis in the small finger hemit joint, you might need to do an arthrodesis.
All right. Now, what are some of the complications we need to be aware of when we're talking about metacarpal fractures?
Malunion,
Uh-huh.
which often presents as apex dorsal angulation after transverse fractures.
You can also get malrotation, which leads to fingers overlapping and problems with function.
Yeah.
Intra-articular malunion is hard to fix, can really mess up hand function.
What about osteomyelitis? How do we manage that?
Osteomyelitis is a serious complication. You've got to treat it aggressively. So you have to remove any implants, debride, put on an external fixator, put in an antibiotic spacer, and give IV antibiotics.
Okay.
Once the infection is under control, then you can do your bone graft and internal fixation.
All right. And what about non-union?
Non-union can happen, although it's not as common in metacarpal fractures.
Okay.
Hypertrophic non-union, where you have a lot of callus, is rare. Atrophic non-union, where there's no callus,
Okay.
is more common.
And what about tendon adhesions?
Another potential complication can limit motion and function.
Okay. Let's move on to phalangeal fractures now.
All right.
Starting with the distal phalanx.
Okay.
And these are the most common hand fractures.
Oh.
The thumb and the middle finger are the ones that are typically affected. Now, how can we categorize these distal phalanx fractures?
Tuft fractures, shaft fractures, and intra-articular fractures.
All right, starting with tuft fractures. What are our typical mechanisms of injury?
Crush injury.
Crush injuries, like
Shutting your finger in a door. Something like that.
What are the key findings on exam?
Usually nail bed involvement.
Yeah.
You need x-rays to see if there's a bony injury.
And how do we typically manage tuft fractures?
So you often need to decompress the subungual hematoma.
Okay.
And there are a few ways to do that.
Ah.
If it's closed, you can just immobilize it.
Okay.
Comminuted fractures rarely need fixation.
What are some key things to remember when managing tuft fractures?
You want to be careful with the soft tissues. Make sure the pulp and nail matrix are lined up correctly.
Okay.
If you think the nail matrix is injured, you might need to remove the nail. Just remember that decompressing the hematoma or removing the nail turns it into an open fracture, so you need to give antibiotics.
Yeah, so important.
Very important.
All right. Shaft fractures of the distal phalanx.
Right.
What are our common patterns?
Transverse or longitudinal.
Okay.
And they often involve nail matrix lacerations as well.
How does displacement factor into our treatment decisions here?
If it's not displaced, it's usually stable because of the surrounding soft tissues.
Okay.
But if it is displaced, you might need to pin it with K-wires.
Okay. Let's talk about intra-articular fractures of the distal phalanx.
Yeah.
What's a key complication we have to worry about?
Avulsion of the extensor tendon insertion, which can lead to mallet finger.
Okay.
And these fractures can be bony or just involve the soft tissues. Dorsal base fractures can also cause mallet finger because the DIP joint gets hyperextended.
Okay. And what about epiphyseal separation?
Epiphyseal separation is more common in kids.
Okay.
It can happen from hyperflexion, and it can lead to a shortened digit and decreased DIP joint range of motion.
Okay. Volar base fractures.
Those can happen from forced flexion
Right.
and profundus tendon avulsion.
All right. So how do we treat these intra-articular distal phalanx fractures?
Depends on the type and how much it's displaced.
Okay.
If it's not displaced, you can just immobilize it.
Okay.
But displaced fractures often need to be fixed with K-wires.
What about mallet finger?
For mallet finger, extension splinting is the main treatment.
Okay.
But you might need to pin it if the patient won't cooperate or if there's a lot of articular surface displacement or volar subluxation of the distal phalanx.
Okay. You mentioned epiphyseal fractures earlier, also known as Seymour injuries.
Right.
Can you explain those and how we manage them?
So Seymour injuries are specific to kids.
Right.
You have a transverse nail matrix laceration, and the avulsed nail plate ends up on top of the nail fold.
So how do we manage a Seymour injury?
You have to irrigate and debride thoroughly. Reduce the fracture, repair the nail matrix laceration, and put the nail plate back under the nail fold to act as a stent.
Okay.
If you don't recognize and treat the fracture, you can end up with some nasty complications.
Uh-oh.
Like osteomyelitis and septic arthritis.
Yikes. All right, let's move on to middle and proximal phalanx fractures. How do we categorize those?
You can categorize them based on where they are: the head, neck, shaft, base, or pylon.
Okay, phalangeal head fractures.
Yeah.
What's special about those?
Those can be unicondylar or bicondylar.
Okay.
You can also classify them based on whether they're stable and whether there's comminution.
Mm-hmm. Neck fractures?
Especially subcapital fractures are less common in adults,
Okay.
but more common in kids.
Right. Shaft fractures.
Shaft fractures can be transverse, spiral, or oblique.
Mm-hmm.
You got to make sure you check for rotational deformity.
Right. And how do we check for that?
You can check for that by looking at how the fingernail lines up during flexion and extension,
Okay.
and compare it to the other hand.
And how do we treat shaft fractures?
Treatment depends on the displacement and stability.
Okay.
So if it's not displaced and it's stable, you can buddy take it or splint it.
Mm-hmm.
If it's displaced but you can reduce it, you can immobilize it in intrinsic plus position.
Okay.
If it's unstable or you can't reduce it, you'll probably need surgery.
Okay.
You can use K-wires, interfragmentary screws, wiring, or a plate.
Okay.
But keep in mind that plating phalangeal shaft fractures can make the finger stiff.
Oh, yeah.
And you might have to take the plate out and do a tenolysis later.
Okay. Base fractures.
Base fractures are usually impacted and angulate volarly.
Okay.
You can tolerate some angulation, but too much will restrict motion.
Okay.
And malunion can lead to a pseudo-clawing deformity.
What is that?
That's where the finger hyperextends at the fracture site and
Yeah.
you get extensor lag at the PIP joint.
Okay. And what about lateral volar base avulsions?
Those often happen when the collateral ligament tears off. And then a specific type of avulsion fracture called a gamekeeper's thumb happens when the ulnar collateral ligament tears off at the ulnar volar base of the thumb proximal phalanx.
And what about dorsal base avulsion fractures?
Those are usually associated with central slip detachment and PIP joint dislocation.
Okay. And lastly, what about pylon fractures?
Pylon fractures are comminuted intra-articular fractures at the base of the middle phalanx.
Okay.
They usually happen from axial loading.
All right. So how do we treat these middle and proximal phalanx fractures?
It depends on the fracture type and location.
Okay.
So articular fractures like condylar head fractures often need to be stabilized with K-wires, miniplates, or lag screws, depending on what the fracture looks like.
Okay.
Displaced fractures often need to be reduced openly through a dorsal approach.
Okay.
All right, so let's talk about neck fractures.
Okay.
If it's not displaced, you can treat it conservatively,
Uh-huh.
closed reduction, and a splint.
Okay.
But if it is displaced,
Mhm.
the head fragment is often rotated 90 degrees, and you'll usually need to do an open reduction and fix it with K-wires.
All right. What about shaft fractures?
For shaft fractures, if they're stable and not displaced,
Mm-hmm.
you can splint them in the safe position
Okay.
to prevent collateral ligament and volar plate contracture.
Okay.
If it's unstable or displaced, you might need to fix it with K-wires, lag screws, interosseous wires, or miniplates.
Mm.
Comminuted shaft fractures might need an external fixator.
All right. And base or pylon fractures, including those PIP joint fracture dislocations.
Yeah, those are tough.
Yeah.
They require careful consideration of the specific injury pattern
Okay.
and whether there's any soft tissue involvement.
Okay. So let's talk about a few specific scenarios.
Okay.
Gamekeeper's thumb.
Yeah.
What's our management strategy?
If the fragment is significantly displaced,
Mm-hmm.
you need to fix it and immobilize it.
Okay.
What about displaced collateral ligament avulsion fractures in the other digits?
Mm-hmm.
If the joint is unstable laterally, you often need to do an open reduction and repair.
Okay. And what about base and pylon fractures in general?
Open reduction and internal fixation are common for base and pylon fractures to restore articular congruency
Right.
to prevent long-term problems.
So what are our fixation options for these?
It really depends. You can use K-wires, screws, dynamic external fixation, hook plate fixation.
Mm-hmm.
It just depends on what the fracture looks like and what you as the surgeon prefer.
What about angular malunion?
If there's an angular malunion of more than 25 degrees,
Mm-hmm.
you'll often need to do a corrective osteotomy to prevent motion loss and pseudo-clawing.
Okay. So now let's switch gears a little bit and go over some key takeaways for the exam.
Sounds good.
What are some things our listeners should remember about metacarpal and phalangeal fractures?
So first, Salter-Harris classification is specifically for pediatric fractures.
Okay, good point.
And for metacarpal and phalangeal fractures, think about surgery if there's scissoring, rotation, or shortening.
Okay.
The jazz maneuver can be useful for closed reduction of fifth metacarpal neck fractures, those so-called boxer's fractures.
Right.
Don't forget that even a small amount of rotation can cause significant overlap of the fingers.
Yeah.
Lag screws are great for long oblique fractures. Put them in perpendicular to both the fracture line and the long axis of the bone, at least 2 screw head diameters away from the fracture.
Okay.
If you can avoid open reduction of comminuted fractures, do it.
Good advice.
You should generally avoid plating metacarpal and phalangeal fractures if you can fix them with K-wires or an intramedullary device.
Okay.
And finally, remember to immobilize these fractures in the safe position. Wrist extended, MP joints flexed, and IP joints extended.
All right. Well, that wraps up our deep dive on metacarpal and phalangeal fractures.
Yeah, that was a lot of information.
It was, but hopefully our listeners found it helpful.
I hope so too.
Yeah. So keep studying hard and good luck on your FRCS exam.
Best of